Thanks very much. Okay, so just a brief outline of what I'm going to talk about. I'll briefly introduce you to what psychology is and why it might be helpful in this disease. Go through what's called the building blocks of behaviour change, looking more specifically at part of that, which is what we call the intention-behaviour gap, looking at some of the differences between the initiation of a behaviour change, so starting a gluten-free diet, and then the maintenance of that over a long period of time. Obviously, it's lifelong. And then, assuming that most of you are not psychologists in the audience, what might we be able to do with this? What can you do with it? And then briefly, I'll talk a little bit about some of the research in children and adolescents, although that's not where my experience lies. Okay, so on a very basic level, psychology is simply the science of thoughts, emotions, and behaviours. And there are two branches of psychology that I think are relevant in celiac disease and adherence. On the one hand, we have health psychology, and this is where we're looking at things like adjustment to illness. We talk about adherence to treatment and medical recommendations, health behaviour change, so looking at things like diet, physical activity, adherence. And how we usually go about changing those things is via looking at things like our attitudes, our beliefs, and behaviours. On the other hand, we've then got clinical psychology, which is more the domain of sort of mental illness. We talk more about symptoms, treatment and prevention, and more sort of woolly or fluffy concepts like emotions, distress, and well-being. So why might psychology be relevant to celiac disease and gluten-free diet adherence? Well, we know that rates of strict adherence are inadequate, so it's a little bit outdated now, but there was a systematic review back in 2009 where it was found that only between 42 and 91% of patients across a range of research studies were strictly adherent. We also know that there's a knowledge behaviour gap. So this is the idea that knowing what you need to do, and this applies to any behaviour, knowing what you need to do is not necessarily enough to guarantee that you will do it, and therefore telling somebody what they need to do is not necessarily always going to be enough to guarantee that they do it. Because celiac disease is a dietary controlled illness, and at the moment gluten-free diet adherence is the only available treatment, patient behaviour is really all we have to work with. What the patient does is the most important factor that determines how well they do and whether they get a good clinical outcome. So therefore, psychology is useful in allowing us to understand the modifiable patient characteristics that are related to poor adherence. I say modifiable because although it might be interesting to know, for example, that there's a difference between men and women, or there's a difference depending on whether you were diagnosed as a child or as an adult, we can't actually change those things. So what we're looking at is things that we could potentially use to target in order to achieve improvements in adherence. And I've got there formal and or clinical practice. So what I do is design kind of formal systematic behaviour change interventions that are delivered as a package to patients, but also a lot of this applies in kind of day-to-day clinical practice, slight modifications that might help patients adhere that little bit better. So the building blocks of behaviour change really explains the factors that are, or the things that need to fall into place in order for somebody to be successful in making a change. So the first one is environment and context. If you're trying to make a behaviour change in a context in which there's no support, there's no availability, those sorts of things, it's going to be incredibly difficult. But even if you have that, it doesn't guarantee good adherence. What's needed next is knowledge. So if you don't know what you need to do or why you're doing it, why you're being asked to do it, chances are it's not going to happen. But as I said before, that's not enough. You then need to be motivated to make the change. But again, we can all probably think of examples from our daily lives where we were motivated to do something, but for whatever reason, we didn't end up following through. So motivation also is not enough. In order to translate motivation into behaviour, we need strategies to translate, to put it into action. So planning would be one of these. However, we can all probably also think of situations where even though we were motivated, even though we knew what we needed to do, even though we had a plan, we still didn't do it because things get in the way. So skills specifically directed at being able to cope with barriers if and when they come up. And so that's sort of what we think of as being the building blocks of behaviour change. These things are going to be necessary but not sufficient, but it's these things at the top that are more likely to determine how well somebody does. So talking to Heidi prior to putting this presentation together, she said, well, the kind of standard clinical pathway tends to be the 3 Ds. So diagnosis, diet and discharge. And really what I'm suggesting here is not anything hugely different, but just a way of expanding this diet category. So in addition to telling people what to do, and I'm certainly not suggesting that that's all that dietitians do, but some more kind of systematic ways of helping people to translate that motivation into behaviour. So one of the things that as psychologists we really like is theory. And this is an example. It's not a particular theory, it's kind of an example. I've put motivation here because motivation tends to form a central construct in most of the theories that we talk about. And we know that people who are more motivated than others will tend to perform a behaviour more so than people who are less motivated. Our theories then tend to have what we call pre-motivational factors, which are things that tell us why some people are more motivated and some people are less motivated. But we know that motivation isn't enough, so we then also have these other factors, which we call volitional factors, or factors that are responsible for turning things into action. And they might have direct impacts on behaviour, but they might also help us explain why some individuals who are equally motivated, some will go on and do the behaviour, whereas others will struggle. So these motivational factors are things like risk perception. So how much risk is associated with not doing the behaviour or continuing to do the behaviour? How important is it? Balancing the pros and cons of doing it versus not doing it, and perhaps symptoms. So we know sort of anecdotally as well as through research that people who tend to do better often are the ones that have higher levels of symptoms, simply because that acts as sort of an immediate motivator for them to do the behaviour, to adhere. The factors that we're looking at when we talk about volition, how do we go about translating motivation into action, are things like skills specific to the behaviour. So for example, when we're talking about gluten-free diet adherence, the ability to identify gluten from labels would be a skill. Planning, how habitual or automatic the behaviour has become. So people who have stronger gluten avoidance habits might be more adherent. And then things like emotions, which we know from a whole range of behaviours. We might be planning to do something, but then something happens, we experience a negative, usually negative emotion, and things kind of go out the window. And the reason that we like theories is because they give us what we call sort of a blueprint for intervention efforts. So knowing that people who score either high or low on these tend to be more or less motivated. Motivation isn't enough, but if we put these things into the mix, we can explain better who ends up doing the behaviour. We can then extrapolate from that if we are to successfully target these factors, it should lead to improvements in motivation and then in turn behaviour. In our evaluation of interventions, if we have measured each of these factors, it also allows us statistically to work out why did it work. So maybe it worked because we successfully improved this, that led to increased motivation and then they did it. Or if it didn't work, we can kind of track back and say, well, why is it that it didn't work? Actually, maybe it's because although we targeted this, we didn't see improvements in it, and that was where it fell down. So the intention behaviour gap or motivation behaviour gap is the basic idea that just being motivated or intending to do something isn't enough to guarantee that you will always follow through. And when we divide people into groups according to whether or not they have a positive intention, so they intend to do something or they don't, and then the other way, whether they're currently strictly adhering or not, we get these 4 categories. So the group who have positive intentions and are adhering strictly are probably not the people that are going to need our help. They're already doing what we're asking them to do. These people at the bottom who aren't currently motivated, aren't really intending to do it, they're probably going to need some sort of motivational help. So looking at why is it important, what are the consequences of not doing it. In celiac disease, though, this group is not very big. Most people are really motivated and are intending to do it. So our biggest concern is this group here. These are the people that have a positive intention. They're motivated to do the behaviour, they're motivated to adhere strictly, but for whatever reason at the moment, they're not able to follow through. Something is getting in the way. So what we're left with is the question of why is it that some people with positive intentions to adhere to a gluten-free diet are currently failing on that? Why aren't they adhering? And so I'm going to talk you through a few different factors that have been proposed as kind of narrowing that intention behaviour gap, and therefore provide us with some guidance on what we might need to target in order to achieve better adherence. So the first one is depressive symptoms. We know that depressive symptoms are more common in celiac disease than in healthy controls. Lots of different studies have shown that. But less clear on whether or not it's something specific to celiac disease or whether most people with a chronic illness of some description also have heightened depressive symptoms. In some of my early work, we showed that depressive symptoms explain some of the intention behaviour gap. So specifically that amongst the group, which was roughly 90% of the sample who had a positive intention, the people who were currently adhering to a strict gluten-free diet had lower levels of depression or depressive symptoms than the people who were not currently following through, suggesting that depression might be something that gets in the way. Pulling all of that information together, in a meta-analysis, we found that there was a moderate relationship or a medium effect size between depressive symptoms and poorer gluten-free diet adherence. All of the studies were cross-sectional though, so we don't know how this works. So it may be that in the presence of depression or depressive symptoms, poor adherence is an outcome because it acts as a barrier to engaging in the behaviours that are needed in order to achieve good adherence. Or it might be that people who already have poor adherence for whatever reason, there's some sort of physiological mechanism that explains why they then end up having higher levels of depressive symptoms. And there's evidence in the literature for both of these positions. Reality is it's probably a combination of the two. So coping strategies are behavioural or kind of thinking strategies that we use in order to cope when difficult situations emerge. Emotion regulation is kind of a subset of those that's related specifically to how do you manage negative emotions that come up in difficult situations. And it's been found that people who have better gluten-free diet adherence tend to have more positive coping strategies. So task-oriented coping being what can I do about the situation, as well as acceptance and reappraisal, which is thinking about the situation differently in a way that enables them to adhere to the diet. The opposite to that is what's called emotion-oriented coping, which is rather than doing something productive to solve the problem, kind of just getting upset, getting frustrated, wishing you could do something differently, but not actually translating that into something helpful. As well as things like distraction, self-blame, suppression, what we would call sort of maladaptive strategies. And we know that people who have better gluten-free diet adherence tend to do less of these things. Interestingly though, it was only the maladaptive strategies that differentiated the good from the poor adherers. So it seems like most people with celiac disease have these good coping strategies. So what we need to be targeting is reduced use of the maladaptive strategies in the people who are not doing well. And probably unsurprisingly, coping was also related to depressive symptoms. Confidence is another one that probably shows this bidirectional relationship where people who are more confident to start with probably do better, but as you do well, you gain confidence because you notice that things are going well, you're feeling better, that kind of thing. And a range of different different types of confidence have been associated with adherence, so kind of general confidence, confidence for engaging in the specific behaviours, ability to balance the gluten-free diet with other things that are going on in your life, perceptions of behavioural control, so how much control do I have over my ability to adhere, bearing in mind that there are situations where it's actually not in your control, and then perceptions of difficulty. So, as part of my PhD a while back, I designed an intervention to improve gluten-free diet adherence, targeting some of these factors. And basically what it showed, without going into too much detail, is that it worked. So across the whole sample, there was a significant decline in adherence scores, which in this case means better adherence, so it is a good thing. And then when we specifically looked at the people who had inadequate adherence to start with, because we recruited anyone with celiac disease, but when we looked at the people who were inadequately adhering at the start, there was an even bigger drop. And this line across here shows the cutoff for what's considered to be excellent or very good adherence, so you can see that the mean score came down into the excellent range. So again, without going into too much detail, kind of proof of concept that by targeting some of these psychological factors, we can achieve improvements in behaviour and adherence. One of the difficulties that we have with a lot of our theories in psychology is that they tend to focus more on the initiation. So what do we do in order to start making a change? But we know that this behaviour in particular needs to be maintained across the lifespan from diagnosis. So we looked at, so this was a review of lots and lots of different theories of behaviour change, and they pulled out the factors that were specific to the maintenance of behaviour change as opposed to starting. So we know that strength of motivation, so people who are more motivated do better, but also perhaps looking at, well, what sorts of things are motivating people was important. Self-regulation, which in this case, we're looking at things like reading labels, doing things in order to avoid contamination, telling other people. So all of the behavioural things that people with celiac disease need to do in order to successfully adhere. The chances are that the more you do those things, the more habitual they become. So as I said before, habit might be related to adherence. And if we lived in a perfect world and nothing ever got in the way, that probably would do a pretty good job of explaining the vast majority of our behaviours. But we know life happens, there are things that get in the way. So some of those things are how much priority people place on their adherence as opposed to other things that are going on in their life, and how much other things in their life might conflict with what they're trying to do in terms of adherence. We know that there are situations where we all suffer from reduced self-control. So at the end of a long, hard, stressful day, we're all more likely to kind of reach for the chocolate cake instead of an apple, perhaps. Our self-control is lowered under those sorts of circumstances. And then social and environmental support, and this can go either way. So if you have very good support, it may be that you can mitigate the influence, potential negative influence of these things, but if the environment also isn't very supportive, it might compound those difficulties. So this was a study that we did, large-scale cross-sectional study in Australia with Jason as one of the co-authors actually, who you heard from this morning, and we measured all of these factors, as well as intention and perceived behavioural control, which we'd previously shown were two of the strongest factors. And we wanted to look at whether these viewing adherence from this sort of lens of maintenance, rather than just the factors that prompt initiation of a behaviour change, made a difference to our prediction. What we found was exactly what we expected. So all of those things that I had up in that diagram were all related to adherence in the expected direction. And I'm just going to go through in more detail two of those things. So the type of motivation, I said before that how motivated somebody is, the strength of motivation is important. What we found was that the types of motivations that were most strongly related to better adherence were these. So enjoying the actual behaviour, it's become part of who I am, it's consistent with other things that matter to me. Down the other end of the spectrum, we had these sorts of motivations which weren't really relevant. People didn't really say, I'm following a gluten-free diet because somebody told me to, although initially that's probably the reason that they did it. And they weren't strongly related to how well somebody adhered. And then in the middle, we had these two groups, one which was predominantly related to symptom avoidance, and then one related to long-term health complications. So as I said, these are the things that were most strongly related to better adherence, down to these ones not very related. What was interesting was when we compared that to how frequently people endorsed these motivations. So these symptom-based motivations were the main reasons that people said they were adhering to a gluten-free diet. And we're not saying that you should replace that. Obviously, if you have a long-term condition that makes you sick, avoiding symptoms and feeling better is going to be a strong reason for why you adhere, but it was the people who also had these sorts of motivations that were actually doing better. Looking then at the psychological resources, so here we were looking at what we called the cognitive and behavioural consequences of having lowered psychological resources. So under each of these 11 conditions, how frequently do you feel tempted to break your diet? And across all of the different reasons, quite a large percentage of the sample said, regardless of the situation, I actually never feel tempted to break my diet. We then looked at intentional gluten consumption. So under those circumstances, again, how often do you intentionally eat something that has gluten in? And that was really rare, which is good. We also then asked, how often under those circumstances are you less careful with your diet? So you perhaps take risks and don't read labels as much. You don't tell the other person. So those self-regulatory things that are necessary to avoid gluten, not doing them as much. And that was a little bit higher. So these were the reasons where people were least likely to break their diet. But these ones, so being busy, having limited time and having a break from the usual routine, which are probably more day-to-day type barriers rather than these ones, were the circumstances in which people were most likely to feel tempted and to intentionally and unintentionally break their diets. We put all of this into an analysis to look at how do things come out sort of in relation to each other. What we found was that social and environmental support and how much control somebody perceived themselves to have were the most important factors, as well as lower levels of temptation and unintentional gluten consumption. So keeping up those self-regulatory behaviours even when you're busy, you're tired, you're stressed, you're unmotivated. We then looked at, knowing that depression and psychological distress is really important, we looked at what happens when we enter that into the model, what changes. And this is where it's really interesting, because in the presence of psychological distress, actually self-regulation becomes really important. So it's when people are feeling a bit down, a bit anxious, if they're not engaging in high levels of self-regulation, so being able to continue engaging in those behaviours, that's where their adherence suffered. And these things were still important, but less so when we accounted for distress. So suggesting that they potentially have a bit of a protective role when somebody's feeling down. So what can you do about it? As I said, really what I'm suggesting is some ways that we can just expand that diet category. So, translating this into an intervention. I haven't done this yet, but I would like to, but also thinking about what might you be able to do when you see patients. So one of the things is encouraging the development of future-focused internal motivations for adherence. So the chances are that everybody with celiac disease, the reason they started a gluten-free diet is because they received a diagnosis and the doctor told them that's what they needed to do. And at that point, that was great. That's what you needed them to do. But over time, symptoms lose power. If you haven't been sick for a long time, you don't remember what it was like, how bad it was. So also encouraging people to think about, well, I feel much better, I'm able to do more. I actually quite enjoy being well and engaging in these behaviours might help. Prompting the patient to identify their personal risky situations. It'll be different for everyone. So when is it that you experience lowered self-control and you're perhaps more prone to lapses? And actually planning for those, because it might be different. It might be that your normal plans don't work when you're really stressed and busy because you don't have time to do it. So you've got to come up with what we call a coping plan. What do I do if this thing gets in the way? Identifying any conflicting priorities, and again, planning or problem-solving ways that you can continue engaging in a gluten-free diet, doing the behaviours that are needed, while also balancing. So when you think about the social burden of having to follow a restrictive diet, some people cope with that by just not eating out socially, but that's a real shame, and it's one of the areas where people say that the biggest burden lies, because they want to be able to participate. These things conflict, so if we can find ways around that, helping the patient to integrate it. Social support was really important, so it may be that actually they need to seek out additional social support, or it may be just educating the people around them, so getting families in and that kind of thing, which I know happens with children, but perhaps less so with adults who have been diagnosed, and talking to people about how they can get other people involved. Normalising or validating any difficulties that they have at the beginning. So because we know that the more habitual something is, the more likely they're able to continue doing it, in order to set up a habit, you need to put in the effort at the start. A habit is not something that you can teach somebody or give somebody on day one. So normalising, we know it's really hard at the start, but over time it will become easier, and that will help. And then identifying any depressive symptoms that might be present, and probably, if we're looking at sort of a potential diagnosis, referral to a psychologist. So that's the one area where perhaps you would need somebody else involved. But there's no reason that I can see why other health professionals, so dietitians, gastroenterologists, GPs, couldn't also be doing some of these things. It doesn't need to take up a huge amount of time, but just supplementing what you're already doing. Okay, sorry, I'm aware I'm out of time. As I said, children is not something that I've ever done my own research into, but really interesting to have a look at the research because a lot of it mirrors what we know about adults. So, for example, a study found that mood and behavioural changes, we all know that mood and behavioural changes may be suggestive of celiac disease prior to diagnosis, so fewer kids are presenting with that kind of classical presentation, and these might be the things that signal a diagnosis to you. A study found that children with celiac disease had a greater risk of a huge range of psychiatric disorders, but their non-affected siblings were at no greater risk. So it is something specific to celiac disease. It's not this shared gene. Adolescents with good adherence displayed more adaptive coping, so very similar to what we found with adults. But they were more likely to get frustrated at having celiac disease and refuse to accept the medical need. So again, some of those emotion-focused coping strategies which really get in the way of people adhering well. And a very recent study, interestingly, found that actually caregivers, so parents and spouses of patients with celiac disease, were also at heightened risk for depression and anxiety. And so that suggests that the burden of the illness isn't just on the patient, it's actually the people around them as well. So the more that we can be doing to embed a gluten-free diet within a person's social network, the better everyone else is going to be. And that's it. This is a picture of me in Poland a couple of days ago getting very excited when I found a gluten-free delicatessen. Thank you.